Hi. So, Vivian, it's so lovely to have you here. So, for those watching at Room Now, which is just so exciting about this whole ACR 2021, I have Dr. Vivian Bykerk with me, who is a fellow Canadian, but has spent a lot of time now in New York. And I'd like to ask you, Vivian, what's going on with the big incident cohort of rheumatoid arthritis patients, ERA and CATCH? Tell me about that and where you think where we're at and lessons learned and maybe where we're going.
It's a big topic, Janet. I'll try and be as succinct as I can. So for anyone that doesn't know, we started recruiting and following patients with new onset RA, even early RA, as in didn't even meet criteria yet, since 2007. And we have recruited over 3,500 patients and followed many of them out to 3, if not 5 years, and some out to 10. And just as a aside, along the way, we took out questionnaires, we added questionnaires so we could answer different questions. But really, we were very interested in how to improve the quality of life of patients. So we had to understand the predictors of remission. We had to understand how to implement changes to improve rates of remission, which indeed we did. And now we're looking at more of the effects of other, we'll call them covariates. So things like comorbidity, multimorbidity. We've seen that about 30% have metabolic syndrome. We've seen, shockingly in Canada, when we did this study, that roughly 30% met criteria for obesity by BMI and another 30% overweight. And both of those groups had 25% and 50% less remission at 2 years. So that had never been shown in early disease. And then there was an interaction effect with smoking, which, by the way, has gone way down. We started out and there were 25% smokers, now roughly 10%, and that's still a little higher than many are reporting. We've been looking at infections. We've been looking at the risk for COVID or severe COVID, which we found to be very high. I think that you might have been on that one. And then recently we're thinking about how to follow people virtually in a better way, because people can't come into visits and they've sort of gotten used to not coming into visits. And also we can't keep asking them to come often for a long time. So we're looking at how to make the physical exam that we see ideally on a screen, but maybe by phone, jive our MD Global with the patient's report of swollen or painful and swollen joints, and so that we can make a patient CDI. So Patient Clinical Disease Activity Index, modeled after the MD Clinical Disease Activity Index. And we're showing that so first of all, it's responsive. If you flare, in other words, your CDI was low remission before, and you go to moderate high, the patient CDI flares too. And so it's pretty, they agree quite highly. So I think that's promising. We have other measures that we use as well, the RA flare questionnaire, which actually works reasonably well as a disease activity questionnaire, and of course the RAPID-3. So, we can rely on patient report in our virtual visits, and we need to get to do that better. And we don't even train patients how to examine joints, and it's already this good.
Right. So, and I think you were poised for COVID before it even happened by looking at the patient derived CDI and the proper calculation of a CDI, and how they really were quite closely linked, especially at the extremes. If you're really flaring and they say they are, it seems to be true. Really, and vice versa. If they're in remission, it seems to be quite concordant. So I think that that's really helpful. So it really sounds like CATCH is looking at patients, asking clinically relevant questions, and then coming back to do epi kind of research on them. But in your other life, not only leading this incident cohort in Canada, your other life, you have things to do with the Accelerated Medicines Program, or AMP. And can you tell me a little bit about what's going on with the AMP area?
Well, I'm going to just interchange there. So we've started a Catch US consortium of early arthritis cohorts in the United States, 5 sites onboarding, and 2 Hopkins and us have been doing it for a while now, getting the bugs out, mimicking a lot of the study as we did the prospective cohort for AMP, and which will hopefully be even better in AMP phase 3, or they're calling it AMP AIM. But we had 3 phases in AMP. They get it all started, teach people how to do synovial biopsies, a lot of rooms doing it, and put together a study, and then develop all the SOPs and test all the pipeline analytic methods, which just completely changed every 6 months because almost like they cubed in terms of the amount of sequencing that could be done at once. So in this latest, and people who have been watching and listening, they will hear the data from this latest round of analytics, which has roughly 72 patients in it. All of them had to have enough cells in their biopsies to go into the analytic pipeline. Measured for each cell line. So these are single cell RNA-seq and protein measuring site-seq studies. So from macrophages, monocytes, fibroblasts, T cells, B cells, and endothelial cells. And each of them have been characterized. So 2 things have happened. 1, we've seen cells we never knew existed. We've seen states that change in different, probably maybe due to medication exposure or time, we don't know yet. And we've also been able to cluster or find 6 different clusters of what are called cell type abundance proportions, or CTAPs. And each of those are quite different. You might get myeloid line, thank you. And fibroblasts in one, you might get very T B cell enriched in another, but it will be there'll be CD4, and then you'll see another one where it's CD8 with a lot of granzyme. So we're sorting through all of these, what seem to be discrete reconstructed RA groups that somewhat associate with clinical findings, but not entirely. So all of that still needs to be understood. I think there's still a chasm between clinical findings and what is seen on histopathology and in the joint. And I think my personal opinion is that we need to better characterize the patients, because we know that 35% of them will complain of a non-articular pain syndrome, because we give body pain diagrams to everybody, and most of those are regional, probably tendinopathies or whatever, and about 6 to 9% are quite widespread centralized pain, and we can't correlate synovial findings with that phenotype, so we need to do better.
Right. So it really sounds like, to wrap it up, that we're getting closer to personalized medicine, and some of these different groups of cell types at single cell level and sequencing, that maybe eventually we'll find a drug that would be more appropriate, or a better durability of a medication or a pathway.
Also, maybe combinations,
right.
One that targets each of even complement. We haven't even studied that yet, but ones that target but don't worsen safety in combination. I think that's where we're going. And then, of course, managing the non-direct synovial-itis that is experienced in other parts of the body, which there's a lot of injury, as you know. It's the first side effect of going on a TNF inhibitor, back pain. You lift something up because you think you're still strong, and you get back pain. So these are the challenges.
Right. Well, I think, your name is, like every ACR, your name is all over the place in a great way. So I thank you very much for sharing your insights. And this will broadcast on Room Now, and we'll have everybody that's listening to follow some of what you're doing with the cohorts throughout the next several years, and maybe decades.
I can't wait to implement what our colleagues are doing. There's all kinds of new autoantibodies to look at.
Yes.
It's very exciting. A lot of interest in lupus and anti-interferon antibodies. I don't know if that happens in rheumatoid. So I think we have a lot to do.
I agree. I'm pumped. You're aimed, and we're both catching up. So thank you very much.
Thanks, Janet.